Hi everyone, welcome to our module on the thalamus, the hypothalamus, and the limbic system. So when I was a medical student, I felt like I understood the cerebral cortex fairly well, and I also felt like I understood the brainstem fairly well. But there are all these structures I call subcortical structures in between the cortex and the brainstem that always confused me. And so in this module, we're going to try to demystify the thalamus, the hypothalamus, and the limbic system, and then in a separate module, I will go through the basal ganglia and how that works. The first thing you need to know about the thalamus is how to find it in a cross-section of the brain. So let's take a look at this coronal section here, and I'm going to use a red pen and mark some of the structures. So notice that we have a black structure going up the middle here. That's the third ventricle, and then it fans out and becomes the lateral ventricles on either side of the brain. Right next to the lateral ventricles, fairly high up, is always going to be a gray structure, and that is the caudate nucleus. And when you're this far back and you can see the third ventricle in your coronal section, then below the caudate nucleus and next to the ventricles is going to be the thalamus. And those are these three structures drawn right here in gray. Next to the thalamus, there's always this white matter track running through, and that's the internal capsule. And you should remember that's next to the thalamus, because many thalamic lesions will damage the internal capsule, and that will cause motor dysfunction and hemiparesis. Next to the internal capsule, you're always going to find two structures that are part of the basal ganglia. The bigger one is the putamen, and the smaller one here is the globus pallidus. And then I'll point out a couple of other structures here just for interest. This is the hippocampus down here. These two little bumps are the mammillary bodies right here, and this black thing here is the substantia nigra. Also, running through the middle here is the corpus callosum, which connects the two halves of the brain. So make sure you can find the thalamus in these coronal sections because they like to show that to you on your board exams. You also need to be able to find the thalamus in an axial section, so let's go through that now. So these black areas I'm highlighting are the lateral ventricles. And once again, up at the top of the screen next to the lateral ventricles is a structure which is the caudate nucleus, and that's right here. And also, once again, next to the caudate nucleus, there's white matter running like this, and that's the internal capsule. The part where it bends is called the genu. A genu means a bend, and then this part down here is the posterior limb of the internal capsule, and up here is the anterior limb. Once again, separated from the caudate nucleus by the internal capsule are two gray structures. The bigger one is the putamen, and the smaller one is the globus pallidus. These are both parts of the basal ganglia. And I'll just point out a couple of other structures of interest here. You have the corpus callosum going like this, and you also have it up here going like this, and then this is the pineal gland right here in the middle of the screen. So the thalamus is called the gateway to the cortex sometimes because all the sensory information goes through it to get to the brain. It's a Greek word that means inner chamber, and it sits right on top of the brainstem, and this is an MRI picture of the head with an arrow showing the area of the thalamus. It's symmetrical, so there are two halves, and you can have right-sided thalamic damage or left-sided thalamic damage. All the sensory systems in the body, so your touch, your pain, your temperature, it all goes through the thalamus to get to the cortex. The only exception is smell. Smell does not go through the thalamus. And then the thalamus also has a role to play in our consciousness, our sleep, and our level of alertness. The thalamus is composed of many thalamic nuclei, and most are named by their location within the thalamus. So, for example, there are anterior and posterior thalamic nuclei. There are also nuclei that are ventral or medial. 5 that I think are worth knowing as a medical student preparing for step 1 are the ventral posterolateral, the ventral posteromedial, the lateral geniculate and medial geniculate, and finally the ventral lateral nucleus. So let's go through each of those 6 nuclei and what they do. So the VPL is where most all of your sensory information comes into the thalamus. So pain, temperature, touch, proprioception, and vibration. It gets inputs from the spinothalamic tract and the posterior column in the spinal cord, and it sends its output to the somatosensory cortex of the brain, and this is how we interpret sensory information in the world. The VPM gets sensory information from the face and also taste, so the inputs are the trigeminal nerve, which is the sensory to the face, and also gustatory fibers, and it also sends its output to the somatosensory cortex in the brain. The LGN is for vision, and some people remember L for light, so it takes input from cranial nerve 2 and sends it to a place called the calcarine sulcus in the brain. The medial geniculate nucleus is for hearing, so it gets input from a lot of the hearing parts of the brainstem, like the superior olive and the inferior colliculus. And it sends its output to the auditory cortex, which is in the temporal lobe. And then finally, the ventrolateral nucleus gets motor info from the basal ganglia and sends it to the motor cortex. And in the module on the basal ganglia, we talk about how the basal ganglia influences the thalamus to make fine motor movements. There is something called the thalamic syndrome that develops when a lesion destroys the thalamus, and usually this is going to be a lacunar stroke. In the stroke module, I talk about the subtypes of lacunar stroke, and one of them is a pure sensory syndrome from thalamus destruction. Patients who get destruction of their thalamus have contralateral or sensory loss, so they lose sensory to the face, arms, and legs in all modalities. And pretty much the only place in the body that's going to do this, where all the sensations from all those locations come together, is the thalamus. And a unique thing that happens in this syndrome is after it resolves, patients can have long-term chronic pain. So on the contralateral side, after they've had thalamic infarcts, the sensory exam may be normal, but they have these severe pains that come on in paroxysms, and they can be exacerbated by touch, and it can be very disabling. So next we're going to talk about the hypothalamus, and since it's hypo, that means smaller or below, so it's naturally found below the thalamus, and there's a picture of it over here. And just like the thalamus, it has many different nuclei with different functions. So some of the things the hypothalamus does is autonomic control. It excites the sympathetic and parasympathetic systems. You may know from discussing the sympathetic response that those fibers start in the hypothalamus and go down into the spinal cord and then exit to the sympathetic ganglia. So that's the hypothalamus starting that whole process. It's responsible for temperature regulation, also water balance, and then it has a major role in influencing the pituitary gland's endocrine function. Just like in the thalamus, there are a number of different areas of the hypothalamus, each with a unique job to do, so let's talk about that now. The lateral hypothalamus is responsible for the sensation of hunger, so if you have a lesion here, you won't be hungry, and this will lead to anorexia, or in babies, it can lead to failure to thrive. In contrast, the ventromedial portion of the hypothalamus is responsible for the feeling of satiety after you eat a meal. So if you have a lesion here, you will never feel satisfied after eating a meal, and you will have hyperphagia and obesity. The anterior and posterior portions of the hypothalamus are responsible for cooling and heating. The anterior portion is responsible for cooling the body off, so this section of the hypothalamus leads to vasodilation of vessels in the skin so that heat will be lost, and if you have a lesion here, you will have hypothermia because you won't be able to cool your body effectively. In contrast, the posterior portion of the hypothalamus is responsible for heating, so this leads to vasoconstriction of vessels so that heat is retained, and if you have a lesion here, you won't be able to heat up to the normal body temperature, and there will be an inability to thermoregulate. And then finally, the suprachiasmatic nucleus is a portion of the hypothalamus responsible for our circadian rhythms. So circadian rhythms are functions in the body that vary with the time of day and whether it is nighttime or daytime, and these are all controlled by the suprachiasmatic nucleus of the hypothalamus. Let's talk about fever, because that is something that closely involves the hypothalamus. So if you have pyrogens in your body from an infection or from an inflammatory process, you know that you will get a fever. And the reason this happens is because substances like IL-1 and IL-6 and tumor necrosis factor enter the brain. They stimulate the synthesis of prostaglandin E2, and as long as prostaglandin E2 levels are high, you will have a fever. This is synthesized by the arachidonic acid pathway, and it's mediated by enzymes like phospholipase A2, cyclooxygenase 2, and prostaglandin E2 synthase. And what happens when prostaglandin E2 levels get high is they increase the anterior hypothalamus's set point, and that's why you get a fever. If you get a really high fever from severe damage to the hypothalamus, and I've seen this happen to people with strokes, they will get a temperature over 42 degrees Celsius, and that's called hyperpyrexia, and it's very dangerous. It can cause permanent brain damage, and what you have to do is facilitate heat loss by throwing cooling blankets on people, putting fans on them, and then you also give drugs which block prostaglandin E2 synthesis, and these are drugs like NSAIDs and Tylenol, and you hope that these will lower the temperature enough to help the patient survive. The hypothalamus also plays a major role in regulation of the endocrine system, in other words, regulation of the hormones within our body. The hypothalamus releases multiple hormones which stimulate the anterior pituitary to release hormones of its own. So for example, thyrotropin releasing hormone, or TRH, is released by the hypothalamus. It triggers the anterior pituitary to release TSH, which regulates the thyroid gland. Corticotropin releasing hormone, or CRH, comes from the hypothalamus. It triggers the release of ACTH, which regulates cortisol levels via the adrenal glands. GHRH is growth hormone releasing hormone, and as the name implies, it triggers the pituitary to release growth hormone. And then finally, GnRH is gonadotropin releasing hormone, and it triggers the pituitary to release FSH and LH, which go on to control ovarian function in females and testicular function in males, and generally to control the levels of androgens and estrogens within our body. There are also some hypothalamus hormones which shut down hormone release, so these don't promote it, they actually shut it down. So dopamine is sometimes called prolactin inhibiting hormone, which helps you remember what it does, which is shut down prolactin release from the pituitary. And somatostatin is sometimes called GHRH inhibiting hormone, so it shuts down growth hormone release. And then when women have high prolactin levels, this shuts down GnRH levels, and this is part of the reason why mothers who are breastfeeding often don't menstruate, because they have low levels of FSH and LH related to the prolactin feedback on the hypothalamus. Antidiuretic hormone and oxytocin are also synthesized by the hypothalamus. The supraoptic nucleus of the hypothalamus makes ADH, and the paraventricular nucleus makes oxytocin. These are both then stored and released by the posterior pituitary, so keep in mind they're made in the hypothalamus but released by the posterior pituitary. And just a little nomenclature here, the posterior pituitary is sometimes called the neurohypophysis, and the anterior pituitary is often called the adenohypophysis, and they both have different embryologic origins, and that's why they're different structures. If you lose ADH production from the hypothalamus, you get what's called diabetes insipidus. So a long time ago, they noticed two types of people with diabetes. They all had polyuria, polydipsia, and so they seemed to have diabetes. But in one group, when you tasted their urine, it was salty, so they named that group diabetes insipidus because the urine was salty. In the other group, when they tasted their urine, it was sweet, so they named that group diabetes mellitus. So that's where the two types of diabetes get their name. Mechanistically, they're very different syndromes, so diabetes insipidus has nothing to do with glucose, it's got everything to do with ADH. And so because you don't resorb water in the collecting tubule of the kidneys, you get polyuria and polydipsia and a very dilute urine. Leptin is a hormone that's secreted by fat cells in the body, and it's involved in food intake and regulation of homeostasis. So the lateral hypothalamus, which is responsible for hunger, gets inhibited by leptin. So when you have a lot of fat cells, it tells you to eat less. The ventromedial hypothalamus, which is responsible for satiety, is stimulated by leptin. So the net result is that leptin release by adipocytes will tell you that you aren't hungry, and it will tell you that you are satiated, and that's what you want when you have a lot of fat cells in the body. Craniopharyngioma is a very rare tumor from a place called Rathke's pouch, which is an embryological structure, and it produces pressure on the optic chiasm, and that gives you a very typical visual field defect called bitemporal hemianopia. It also puts pressure on the hypothalamus and can cause the hypothalamic syndrome. So let's talk about the hypothalamic syndrome. This is where you get diabetes insipidus from loss of ADH. You get fatigue from low cortisol levels because you've lost cortisol releasing hormone. You get obesity and you lose temperature regulation. So if you see all of these four things, they are describing a hypothalamic syndrome. So for the remainder of this module, we're going to talk about the limbic system, and this is a collection of neural structures below the cortex that's responsible for things like emotion and long-term memory and also smell and behavior modification, and it also has some role to play in the autonomic nervous system. So the limbic system is confusing for a couple of reasons. First of all, its functions are sort of nebulous and hard to define, and secondly, its structure is very bizarre. So look at this picture over here on the right. This shows the main components of the limbic system. So there's this big C-shaped thing that goes around the top, and that's the cingulate gyrus. In the middle of this is the thalamus, which is not part of the limbic system, but just to help orient you, it's drawn there. There is something called the amygdala, which is a small round thing right here. This is the hippocampus right here, and then this is the fornix right here. So all these structures have a very strange shape, and they come together to do the function of the limbic system. And probably the most important thing to know is just some of these names I've listed over here. You should recognize that those are all pieces of the limbic system. So there are a couple of clinical syndromes associated with the limbic system that you should know about, and the first one of these is Kluver-Bucy. So this is when damage occurs to the amygdala bilaterally. Those are found in the temporal lobe, and patients with this condition get hyperphagia, so they eat all the time and they gain weight. They also have a symptom called hyperorality. They tend to examine things with their mouth, and then they exhibit this weird sexual behavior where they like to mount inanimate objects or do other atypical sexual activities. And then finally, they have visual agnosia, so they don't recognize objects that are presented to them. People with agnosia sometimes will be looking at their body, but they cannot recognize it and process it in the brain. And this occurs as a rare complication of herpes simplex virus encephalitis. If you get a lesion to the hippocampus in the temporal lobe, you get anterograde amnesia, so you cannot make new memories. You'll remember very old things, but new things that happen after the lesion you won't remember. And the hippocampus is very sensitive to hypoxic damage, so It can be damaged by an infarct to the hippocampal branches of the PCA or also to those anterior choroidal arteries that we talked about before. And then finally, let's talk about Wernicke-Korsakoff syndrome. So this is a syndrome that happens to alcoholics who don't get enough thiamine. So Wernicke is acute encephalopathy, and it's usually reversible. Korsakoff syndrome is a chronic neurologic condition that's usually permanent, and most people get Wernicke's either once or several times and then eventually develop Korsakoff syndrome. Both syndromes are associated with thiamine, which is vitamin B1 deficiency, and alcoholism. Alcoholics don't eat enough thiamine, and they also don't absorb it very well. On pathology, the classic finding is atrophy of the mammillary bodies, which remember are part of the limbic system. About 80% of patients with both conditions have atrophy of the mammillary bodies. And then there's also damage to the thalamic nuclei on pathology of patients with Wernicke-Korsakoff. So a patient with Wernicke's is usually going to be an alcoholic who presents with visual disturbances and nystagmus on physical exam. The person will have gait ataxia and they will be very confused. And you can often reverse this by administering thiamine. A person who has Korsakoff's is going to be an alcoholic who's probably had Wernicke's before, and their main problem is going to be amnesia. They're not going to remember recent memory things in particular. They won't form new memories, and they do something called confabulation. So because they can't remember, they make things up. So when you ask them about something that happened yesterday, they make up a story, and the reason is because they can't remember. They also show a general lack of interest or concern, and they can have personality changes. And remember what I said, this is usually permanent as opposed to Wernicke's, which is often reversible. You should know that you can precipitate Wernicke's by giving glucose without thiamine. So thiamine is a cofactor for glucose metabolism, so glucose will worsen a mild thiamine deficiency in someone who's borderline. And the way you avoid this in the ER is when alcoholics come in, they're administered what's called a banana bag, and it's called a banana bag because it's yellow in color. It's given IV, and it contains thiamine, folic acid, and magnesium sulfate. And so this is basically given to any drunk who shows up in the emergency room, and that way you don't have to remember your biochemistry. You're automatically giving them thiamine in case they're deficient. And that concludes our module on the limbic system.